Yeah, so as Chris, mentioned, I'm dual fellowship trained in VIR as well as neurointerventional radiology or neurointerventional surgery, as it's called as well. And the topic today I'm going to discuss is acute stroke intervention. Here are my disclosures. So before diving into acute stroke, I just wanted to kind of touch on, I know this is the next topic as well, but just sort of a broad overview in neurointerventions. A couple of years ago, myself and Marty Radvani, who's another dual trained IR neurointerventionalist, we were guest editors for seminars in interventional radiology, which for any of you who may not be aware, this is really a great, it's a quarterly journal. Should be going to now, I think, 6 times per year, but it's really kind of like each edition is sort of a mini textbook of sorts, but very updated, of course. So this was, like I said, from 2020 in the summer. And so it covered a lot of different neurointerventional topics, from acute ischemic stroke, carotid revascularization, angiography, head and neck tumors, et cetera. So really a good resource for anybody who might be interested in learning a little bit more about sort of the variety of neurointerventional. So acute ischemic stroke, stroke is really a kind of a generic bucket term for some kind of an acute neurologic change. So we call it TIA, transient ischemic attack, if it's transient symptoms that resolve within 24 hours. And then there's 2 subtypes of stroke, hemorrhagic, which is the minority, 15% or so of stroke cases, and then ischemic stroke, which we'll talk about, which is the majority, about 85% of stroke cases. In the US, there's still about almost 800,000 acute ischemic stroke cases per year. It's still the leading cause of disability. It's improved, so it's the 5th leading cause of death versus it used to be the 3rd leading cause just a few years ago. But, fortunately or unfortunately, depends on which way you're looking at it, but up to 80% of strokes are estimated to be potentially preventable. And that's, getting into risk factors such as diabetes and hypertension and hyperlipidemia. So if we can tackle those risk factors, potentially we could prevent a lot of stroke. But, as it stands, it's still a very common disease and certainly a very acute emergent disease. Often you may hear the sort of phrase time is brain. And the reason why is that, in stroke, every second, every minute, brain cells and those neuronal connections are going to be dying. And so potentially up to 2 million neurons every minute can be dying. So certainly in my mind, when I'm seeing a stroke patient and getting the team activated and, getting things moving, I'm really kind of cognizant that, every minute of delay, every minute something else is getting in the way is potentially leading to not just more damage, but worse outcomes over time. And so we want to move fast. Faster recognition, of course, will lead to the opportunity for a better outcome. One, mnemonic to keep in mind is be fast. Fast, you may have heard in the past, face, arm, speech, and then time to call 911. The B part is really trying to address the posterior circulation in terms of balance or eyes. So that's the vertebrobasilar system or the posterior cerebral arteries, for example, keeping in mind that stroke can affect, of course, the vertebrobasilar or posterior circulation. Treatment options currently are IV alteplase. That's really standard of care for patients presenting within 0 to 4.5 hours of last known well. There's some, certain sub criteria, but nonetheless, it's standard of care within that acute time period. But again, it requires fast recognition, of course, showing up to the emergency room quickly, and either the patient or some family or friends to really be able to clearly identify when they were last okay. Potentially up to 9 hours since last known well has been expanded as far as IV alteplase, utilizing some advanced imaging techniques such as perfusion imaging or MRI. A couple of trials that came out in the last few years showing that there's that opportunity. Tenecteplase is another thrombolytic agent. There's some increasing evidence for utility and potential improved efficacy over alteplase in acute ischemic stroke. And so the advantages of that is it's a single bolus dose compared to IV alteplase, which is a bolus dose plus a drip. So a drip and ship, sometimes you might hear that term. It's cheaper currently than IV alteplase. IV alteplase is about $8,000 per dose versus about $5,600 for IV tenecteplase. And it actually has higher fibrin specificity. So a few of the trials that have been using IV tenecteplase have actually shown that even a large vessel occlusion stroke, which tends to be more resistant to IV thrombolytic effect, tends to clear up better or recanalize completely with IV tenecteplase over IV alteplase. And then finally, there's endovascular thrombectomy, which since 2015, we've had multiple ongoing positive, trials coming back to back, showing it's clearly a superior therapy than IV alteplase alone for patients who have a large vessel occlusion or LVO stroke. Now we're looking at patients, between 0 to up to 24 hours of last known well as far as standard of care. And this is inclusive of now, again, with further trials and data, anterior and posterior circulation LVO strokes. Just kind of a brief overview, and I'll make these slides available so we don't belabor them, but there's been multiple trials. So for example, in this meta-analysis, which included 12 of the level 1 randomized trials, we had obviously a fairly even distribution of thrombectomy plus medical standard of care, IV alteplase, of course, when able, versus just medical standard of care alone. And when you look at endpoints, and there's multiple things we could look at, but one that really kind of stands out to me is the NNT, or number needed to treat. Really 5.4 is across all the different trials. It's as low as even 2 to 3 number needed to treat, meaning that for every 3 patients or 2 patients you treat, somebody will benefit. So even if you treat 5 patients, will have significant benefit to where they're functionally independent at 90 days and beyond, or that you're preventing that functional dependence. So you're really improving and shifting their clinical outcomes significantly. There's very few things in medicine that have NNT that are kind of this low. If you look at PCI, percutaneous coronary intervention for heart attack, or STEMI, the NNT for that is somewhere between 25 to 50. So it's really, you're talking about, multiples improved outcomes as far as with stroke intervention compared to many other interventions. For thrombectomy, we start with some neuroimaging triage. We look at the CT scan of the head, CT of the head and neck, as sort of a minimum kind of imaging. We want to know what the brain looks like and what the pipes look like. Perfusion imaging can be utilized, depends on the scenario, time since last known well, local resources. But one of the things I've found it very useful for over the last couple of years is to increase sensitivity in detecting medium and distal vessel occlusions. It really can help highlight, that there's a perfusion abnormality, and ultimately lets you go back and look at the CTA to see maybe there's a more distal lesion that's easier to find looking at the perfusion scan. Certainly, if you have MR available, there are some centers that use MRI primarily. That's a great tool, but that's less often available in that acute setting. CT scan is, generally speaking, much easier to obtain. IV thrombolytics are certainly complementary to endovascular thrombectomy, so we don't want to deny anybody, and based on the current evidence, there's no reason to skip IV thrombolytic therapy with alteplase or tenecteplase. As I said, it's complementary. Perhaps in the future, there will be trials that show that maybe they just go straight to the cath lab, and it becomes kind of akin to sort of that STEMI cath lab pipes kind of model, where you need to get them to the lab, do the imaging there, and then open up the vessel as quick as possible. Typically, thrombectomy procedures are performed from a transfemoral approach, but there's increasing evidence for using radial access for thrombectomy procedures. Here's just kind of an overview of some of the different tools and techniques that are available, going back to the Mercy device, which was really the first mechanical thrombectomy device for stroke. It's no longer available, but nonetheless, you can see kind of it's this corkscrew that sort of wraps in and around the clot, and it's pulled out. And then you fast forward to 2012, and then even, of course, more currently, there's so many different tools and combination of techniques using stent retrievers. So that's sort of a stent that's on a long wire, in combination with large bore aspiration catheters. So really a lot of different tools and techniques that are available. So I'll present a case of a 91-year-old male. His last known well was about 12 hours prior, basically the night before, presented in the morning as a wake-up stroke to the emergency room after his wife recognized he was weak on the left side and had dysarthric, so sort of garbled type of speech. As I mentioned, his wife found him. He lives with the wife independently, and his modified Rankin score at baseline is 0. I have a little slide to discuss what that means. His NIH stroke score was moderately high, so 14. And then he wasn't an alteplase or tenecteplase candidate due to his last known well being 12 hours prior. So he got kind of a combination of CAT scan, CT angiogram of the head and neck, as well as perfusion imaging. So just a quick overview of modified Rankin score and then NIH stroke score. Will, just again, these slides will be available, but you look at MRS of 0, that means they were totally normal and asymptomatic at baseline, all the way to an MRS of 6 is somebody who's dead. Certainly what we're trying to prevent with stroke intervention is, that shift towards those worse outcomes, 3, 4, 5 on the MRS scale. So we want to kind of improve their odds. And that's what all those different trials showed, is that at 90 days, MRS of 0 to 2 was considered good. That those patients were much more likely to have a good MRS where they have either no or maybe very slight disability at 90 days and beyond with stroke intervention. And NIH stroke score, it's a good tool to recognize, be aware of. Many hospitals and programs, you might even be able to get certified on. It's very straightforward. So it's really just being able to go through that detailed checklist and score the patient. And as you can see, our patient would be kind of a moderate stroke with a stroke score of 14. So on the dry CT scan of the head, kind of the key thing that kind of came away, there was no hemorrhage, there was no mass or tumor. The arrows are pointing to the distal right middle cerebral artery, showing it was very bright. So that's kind of what's called a hyperdense MCA sign. So that's clot within the artery there. That's occluding flow, and that correlated with the CT angiogram, which showed that there was abrupt occlusion of the distal right middle cerebral artery. You can see the left side, the contralateral side for comparison, showing that's normal and open. And then he got perfusion imaging as well, as I mentioned. So these two maps, the CBV or cerebral blood volume map, showing that the volume of blood getting to the brain is normal or equal between the right and left side, but the TTP, or time to peak, showing delay. Basically, the blood is getting to the right side of the brain, but in a very delayed fashion. So that's what that kind of darker red area is showing, is that it's increased time to peak there. So the summary of the neuroimaging is that there was a hyperdense right M1 or MCA sign. Aspects of which I have a slide on was 10, meaning that the brain itself, the parenchyma, looks good. The head and neck CTA showed type 3 arch, not a surprise in a 91-year-old, but kind of here was the kicker of the case, was he has situs inversus totalis. So all of his organs are, visceral organs are flipped right versus left. But of course, it also confirmed the large vessel occlusion of the middle cerebral artery. And then the CT perfusion confirmed there was a large area of right middle cerebral artery ischemia without a significant core infarction. So very favorable imaging, kind of with the exception, if you will, of the anatomy. So just a brief overview of the aspects. It's really looking at 10 different discrete areas within the middle cerebral artery territory and giving them a point apiece. And then for every area that you lose differentiation of the gray and white matter on the CT scan, you subtract a point. So an aspects of 10 means it's completely normal looking brain. Down to a 0 would mean that that whole middle cerebral artery territory is infarcted and already dark or hypodense on the CT scan. Arch types, just a brief overview. Type 1 is normal sort of young patient anatomy. All the great vessels arise from the top of the aortic arch. And then with time and age, they sort of slump forward and kind of get really more exaggerated. And so this patient, not surprisingly, at 91, has a type 3 arch. So here's his CTA. This is a reconstruction of the CTA, kind of highlighting that the type 3 arch is there, in addition to that situs totalis inversus that he has as far as his anatomy. So here is the course of the right common and internal carotid artery all the way up to the intracranial occlusion. And again, this is what that type 3 anatomy looks like. So you can see it's kind of very exaggerated, such as in his case. Here's a previous chest x-ray from several years prior. It's got, of course, on top of it, a very big heart. But you can see that this isn't a new finding. This is not mislabeled. This is an accurate representation of his anatomy with all of his organs flipped left to right. So the intervention, we always kind of will at least make an attempt whenever we think possible to come from a groin or femoral approach. Here is sort of the setup or the tools I utilize. And to boot, he also had a lot of iliac tortuosity and abdominal aortic tortuosity. Again, we kind of commonly see this in older patients. So here's a little fluoroscopy showing just that big loop of the iliac artery. So that was sort of the first hurdle to face, and got that straightened out with a pretty stiff wire. And ultimately got a a catheter and a wire up to the origin of that common carotid artery, the right common carotid artery. But what we can see on the image to the right is that the tip of my 90 centimeter length sheath, which is a standard sheath I use for these cases, and that's pretty much as long as they come, was just barely at the origin of the common carotid artery. So with all that tortuosity, in essence, I lost a lot of length, and there was no way to make the catheter any longer. So even though I was able to hook that, with the wire and the diagnostic catheter, I just didn't have any more length on the Neuron Max or the guide catheter to get into the common carotid artery, to let alone do any kind of intracranial intervention. I felt that trying to come from a radial approach on either side would probably be unsuccessful, again, with that exaggerated type 3 anatomy. So what I ended up deciding to do was have the anesthesia team intubate the patient, and I did an ultrasound guided access directly of the common carotid artery, which tends to be, within the neck itself, usually pretty straight, and actually the anterior wall is usually pretty disease-free. So that's certainly a tool in the bag. So here's a couple of pictures showing the micropuncture needle access using ultrasound guidance and modified Seldinger technique, and then just a picture of the sheath in the neck. We of course covered up the patient so everything would stay sterile, and then we were able to do the angiogram, which confirmed that distal right middle cerebral artery occlusion correlating with that earlier CTA, and then put our large bore aspiration catheter as well as a smaller microcatheter, and then place the stent retriever. So a combination of aspiration plus a stent retriever, and then pulled everything out after 5 minutes of having the stent retriever deployed. So the stent retriever will kind of incorporate into the clot, and then use the combination of the large aspiration catheter and the stent retriever to kind of cork the clot. And so this is sort of what that technique looks like. You sort of cork them together, and then you pull both of them out as a unit. So that is what gets the clot out. So this is what it looks like in the brain in this particular case. So you can see the stent retriever, the twines of it extending out that M2 branch of the middle cerebral artery, and then approximately that large bore aspiration catheter. And this is what it looks like when they kind of cork together. And then this is what the angiogram was before the intervention. And then this is what it was after the intervention. So you can see we've now opened up all of that middle cerebral artery territory with complete reperfusion, what we call TICI-3 flow. So we got everything opened up with one pass of that combined technique. We closed the right common carotid artery access site with a 6 French angioseal, verified that it looked good under ultrasound. There was no neck hematoma, anything of the sort. And then patient was extubated right on the table, and he did really, really well. He had rapid symptom improvement. And then an MRI of his brain the next day showed just that teeny tiny area of punctate infarct involving the anterior insular cortex. So really a very minimal kind of stroke. And so not surprisingly, he had really kind of no deficits with NIH of 0. He was found to be an AFib, not a surprise with that big heart that he's got. And then he was actually started straight away on Eliquis, and then sent home on the 3rd day post-intervention. And then at 90 days, he was doing well, still independent, living with his wife, and MRS of 0. So got him back to his baseline. So kind of a little bit interesting case. And here's a few different papers. So it's not exactly unheard of, sticking the carotid artery to do a stroke intervention. There's plenty of literature around that. So with that, if there's any questions, I'm happy to take that, or you can contact me by email. Again, thank you for the opportunity to present.